sent it out last time as
will
well.
now be recorded.
So this is our second meeting for the overdose data to action strategy that we're working on, peer networking and referrals from the ER. I think we'll just let people go around and introduce themselves. I will, I can see all the names up, so I'll just call you by name and feel free to unmute and let us know what organization you're from, your name, and your title. So I'm Tiffany White. I'm the Behavioral Health Program Manager from OACHC. And Ashley, you're next on my little list here.
Hi, everyone. I'm Ashley Ballard. I'm the Chief Quality Officer for OACHC.
Nikki? I think you're muted, Nikki. From OSU, are you on?
I am. Hi, I'm Nikki Kritikos. I'm a family nurse practitioner and Chief Operations Officer at OSU Total Health and Wellness.
Thank you. And Dr. Emily Kaufman?
Hey everybody, sorry I'm late. I was on another phone call and I had to download the app. So Emily Kaufman, I practice emergency medicine primarily, but I also practice inpatient medicine. And I'm hoping my social worker, Haley Bauer, will join. She was having some issues, but hello.
Thanks for joining. Jennifer from Southeast?
Hi, this is Jennifer Fraioli. I'm the Director of Compliance QA/QI here at Southeast, and Sandy Stevenson is with me, and she is our Chief Healthcare Officer.
Great, welcome. Audrey?
Hi, I'm Audrey Knapp. I am from Lutheran Social Services Health Center at Faith Mission, and I'm the Director of the Health Center.
Thanks, Audrey. Melody?
Hi, I'm Melody G. I'm from Lower Lights Christian Health Center, and I'm the Chief Quality Officer there.
I'll let Cynthia get logged in, and I will skip over to Candy.
Hi, I'm Candy Reinhardt. I'm the CEO of OSU Total Health and Wellness.
Thank you. Dr. Dana?
Hi guys, Dana Belangen, CMO at OACHC. Thanks for being today.
Thanks. I'm going to go back up to Cynthia. I don't know if you're connected to audio, but we're just doing quick introductions of what organization we're from and who we are.
I'm Cynthia. I'm the Behavioral Health Manager at Lutheran Social Services, the health center here.
Great, thank you. And I'm going to move down to Allison from OSU.
Yeah.
Allison, just either mute your phone or your computer. I think you're creating feedback.
Can you hear me?
You still have an echo. If you're dialed in on the computer audio and your phone, just mute your computer, or you can pin to your caller ID information by hitting the little gear in the top right corner. It should give you an audio pin. I'll let you do that, and I'll hop over to Haley real quick. Are you there?
Oh. Did you say Haley?
Yep, we can hear you. Just let us know who you are, and we're just doing quick introductions.
Oh, okay. My name's Haley. I'm one of the ED social workers at OSU East.
Thanks. Karen O'Brien.
Hi, I'm Karen O'Brien. I'm Director of Health at Lower Lights Christian Health Center.
Thanks, Karen. I'm going to go back up to Allison Miller. Did you get your audio going?
Hey, it's Emily Kaufman. She's here. She texted me. I think she just had to step out for a second. She's here.
Okay, no worries. Kelly Steele.
Good afternoon, everyone. I'm Kelly Steele. I'm the MAC program manager with Primary One Health.
Thanks, Kelly. And Stacy.
Hi, I'm Stacy Swenson. I'm the Director of Behavioral Health and Social Work at Primary One Health.
Great, thank you. I think the only person that I skipped over is Lindsay Rodenhauser.
Hello, Lindsay Rodenhauser with Franklin County Public Health.
Hey, Tiffany, I'm not sure. Did Sarah introduce herself?
No, I did not.
Nope, I don't think. Sorry, Sarah.
That's okay. My name's Sarah Parada. I am the Behavioral Health and Social Services Manager at Heart of Ohio Family Health Centers.
Great. Is there anybody else?
Tiffany, Cynthia Lowe, this is Audrey from Lutheran Social Services. Cynthia Lowe, our Behavioral Health Manager, joined also, and I'll let her introduce herself. But
Oh, I did already. Audrey.
okay, sorry, I must have missed that. I'm sorry. Just want to make sure.
It's okay.
I'm Jessica Williams, Franklin County Public Health. I'm an injury prevention liaison on the CDC OD2A grant.
Great, thanks, Jessica. So Dana, if it's okay with you, I was just going to quickly highlight the strategies that OACHC is working on as part of the OD2A grant, and then I'll let you kind of guide us in conversation. Does that sound okay?
Sounds perfect, thanks.
Yep, so I'm going to share my screen quickly. We just thought it might be helpful to orient everybody once again as we're working with OSU Medical Center and sort of the reasons that we connected initially and just what the strategies are that OACHC is working on as part of the OD2A grant. So this is something that our health centers have seen. We shared this on our very first call with all of the FQHCs on the line. And I think where we overlap with OSU MC is on strategy 4 and strategy 7. I'm not sure that we've explored really working together on strategy 4. I think we're mostly focused on 7 right now, the providers and health system support. And so some of the outcomes and the goals that OACHC identified as part of our prevention strategies are in the 3 bullets there. Specifically, I think we're working on the last bullet, increased referrals to evidence-based treatment for opiate use disorder. So getting patients from the ED into the FQHCs. Similarly, strategy 6, which is one that just OACHC is working on out of the group of partners on the call today, again has those referrals, the increased referrals to the FQHCs, and then best practices, evidence-based treatment. And so I think that's part of the networking that we wanted to do with this group and why we wanted to invite all of the health centers to get some peer discussions going about treatment and best practices, and then increased access to treatment for our patients. So 7, again, is really where we align, I think, and I'll let Allie or Dr. Kaufman or whoever, if anyone wants to speak up on the strategies that you guys have identified or specifically some of your outcomes and goals, but I just wanted to throw this up on the screen. I'm a visual person. I feel like it's helpful to lay it out. So does anybody want to comment on that?
This is Emily Kaufman. Just a question about deliverable 4, strategy 4. Are you guys, in terms of looking at PDMP and ORs specifically, are you guys going to embed that in your FQHC in terms of your, I don't know what the electronic platform is. Is that something you guys are looking to do?
Yes, yes, I think that the health centers either already have it integrated with their EHRs and they're not all on the same ones. We have a variety, or that is something that we are working with them and helping support as the grant progresses.
Okay. And then did you guys need, somewhere along the line, it was thought, and just again for clarification, that OSU was in a position to help with like, you know, IT support to make that happen with the Board of Pharmacy. Is that something that these centers need or don't need, just in terms of point of clarification?
I'll let Tiffany answer, and I don't know if we know enough about what you're talking about to completely answer, but we are working with CliniSync, who is the partner through the Health Information Exchange, trying to help where it's not already integrated.
Yeah. Okay. I would echo Dr. Dana. I feel like we don't know what we don't know. If any of the health centers might know, if that would be helpful to them. What we've done so far is meet with them and ask them how integrated ORS is into their system, how easy it is for their providers to be looking at it before they prescribe, and how frequently they think the providers are looking at it before writing a prescription. And that's sort of where we've stopped with that strategy, or not stopped, but that's as far as we've gotten, I guess, in year one.
Okay. Okay. Understandable. Yeah, because OSU, what we have, and we're an Epic-based platform like Ohio Health. Mount Carmel's transitioning to that as well. We have had ORS embedded within our electronic record system for a couple of years now. And it's now, I mean, they're tracking it to a certain degree, but essentially any narcotic prescription or any controlled substance, you know, you're obviously not going to get a ding, but we are tracking it, but it's embedded, so it makes it much easier to track before prescribing or but if that's something that we can help with from our IT folks who did that, you know, depending on what the platform is, you know, let us know. Because there's been, from our end, with Franklin County, strategy 4 has been a little ambiguous for us. For the health systems, I think it's a little stranger to do, but the strategy 7 is a little bit clearer to us.
Yeah. Did you guys create some provider training for use of ORS and kind of best practice? Because at one point I thought I had heard that.
I don't know. Allie probably wouldn't know this. Well, Allie maybe do. To be honest, no. When it happened, there was a lot of messaging from our institution. When we prescribe, it's actually like embedded with like an ICD-10 code, and it gives you a flag if it's, you know, prescribing, you know, beyond a certain number of like morphine equivalent doses. But in terms of like universal education, when it happened, no, we did not. Now, that being said, there may be something now, because that sort of pain prescribing piece is a whole separate like part of the organization. But before it was enacted, I don't think we really had formal training other than messaging. This is what we're doing.
Okay, thank you for that clarification.
Yeah, I think we can explore maybe how we can work a little bit more together on that. Allie and I just had some side conversations before the call, so there's definitely opportunity, and I know we have our all partners call next week too, so we could discuss it a little bit further for sure.
Yeah, this is Allie. I think I got back on now, and I'm not sure if like Lindsay or anyone from Franklin County is on, but we were just talking kind of internally, like what OSU could contribute to strategy for, you know, like we could maybe do some more like in terms of analysis of our ORS reports, or maybe more provider training or something like that. But I think the needs of like the health centers versus Ohio State might be different. It's just we're not quite sure what the need is. But if there's anything that we can collaborate on, we could do that.
Do any of the health centers that are on want to chime in? Is there anything that sticks out that you would want assistance with? Okay, well, we can definitely come back to this topic or just strategy for specifically, I think. So
Tiffany, this is Allie
that's
Steele. Sorry.
Yep.
I do have a question for Allie or Dr. Kaufman. I think I heard Dr. Kaufman, you say that you have had ORS integrated to access it more easily, but that you're not kind of monitoring and kind of reacting to kind of the high risk prescribing, like, because that's the one piece I think might be helpful for us.
Yeah, so sorry, I didn't give the full picture. So we actually have, I just didn't know, I didn't give you the full picture here. We actually have dashboards, and they are to link every prescriber in every single department. So I work in 2 departments, so I can log into my essentially opioid dashboard, and it will show how many prescriptions I have, and this is separate than like ORS, but it will show you over, you know, a certain time period how many prescriptions you've done, and it was a little bit of a problem originally because they were including buprenorphine in there, so obviously it's a very high morphine equivalent dose. It's like typically 480, and so they were, when they first started doing the dashboard, it was including the medications for opioid use disorder, and so obviously I would flag as a high prescriber, but they finally got that sort of removed. But no, we have metrics in every department. It's meant that we review this. In the surgery departments, they're talking about, this is a whole separate measure at OSU, but they're actually looking at sort of coming up with protocols for certain procedures, say like a lap cholecystectomy, it's like a gallbladder surgery, where this is sort of the national average, and this is the metric you should be prescribing for opioids. And if you're someone in the department who is falling like way outside that measure, like, you know, way too high per se, the department itself, with guidance of our addiction medical director, is supposed to sort of more or less provide education and, you know, rein that person back in. So we do actually have dashboards. Now, in terms of enforcing and punitive actions and what's being implemented, I think that's sort of in development.
Okay, yeah, that was going to be my question. I think once we get ORS integrated, how do we, like, what protocols and how do we put in place, and how do we, you know, address some of those, like some of those issues? So thank you.
And I think they're aiming for education, not punitive measures. Education, you know.
Right. Yeah, I was going to echo the education piece, and then I was also going to echo or add that from a MAT program standpoint and a controlled med prescribing standpoint, I think the other thing for everybody to consider that would be a best practice is how are you going to do compliance reporting that verifies that ORs are indeed being run, even now that they're integrated at the frequency that you expect.
Absolutely. Very good question. Very good statement.
Ideally, as part of this initiative, we'd like to help move the provider needle in all of your health centers to, it's so easy to run that we're just going to run it every time we prescribe a controlled substance. That's like the ultimate aim.
This is Jennifer from Southeast. I don't know the background behind our ability to do this, but my understanding is that ours does run automatically every time a controlled substance is prescribed. And now actually we've been talking about educating prescribers on running it at other times as well.
Yeah, and one other thing I can add that OSU has implemented, I believe, Emily, correct me if I'm wrong, we have now a best practice advisory. If someone is over a certain number of MME, then it's sort of like something like pops up.
Yeah, it was 90, but it may actually be lower now, maybe 50 morphine equivalent doses, and then you have to associate a diagnosis and justify why you're prescribing. So every time I prescribe buprenorphine, I get this pop up, obviously.
Yeah, which is like a major pain, and I don't think that's like a best practice that we want to try to move all of the health centers towards. It's one thing if you're talking about pain medication, but until the systems are smart enough to take the MAT, MEs out, it creates real problems and more aggravation for prescribers who are MAT prescribers, I mean.
Yeah. I don't want to tell you how many steps I have to go to electronically prescribe MAT. I have to go through about 8 steps, and then I have to, anyway, it's interesting.
Yeah. I don't think that's the aim that we're shooting for. I think we just want to get them embedded as readily and as easily as we can, so that it takes us few steps for the provider to run the ORS report. And we want to somehow come up with some provider education or messaging that helps move them towards doing it every time they're prescribing a controlled substance. If we can get there in the next couple of years, that will be a huge success, I think.
Yeah, it really was a game changer. I mean, essentially, depending on what platform I'm logged in, if I'm in my ED platform, when I go to discharge somebody, it's essentially just like a hyperlink, and I just hit it, and then it pulls right up. Now, there are sometimes, if there's a few drawbacks. Sometimes, like, you hit it, and if somebody else, like, say you're working with a nurse practitioner or a physician assistant, if they've already queried their report, then you may not be able to get in right away. So it's like sometimes it's only like one-time access, but it's same thing on inpatient medicine. In the discharge platform, there's like a hyperlink, and you hit it and it pulls it up. And it's typically just the last 12 months. So if you really want the full, ORS report, which is much more complex and has, a lot more like code, it gives you a lot more data, then you have to kind of get out and then get within the independent ORS site.
Yeah, and I work with NextGen, and the way that it works is it's embedded as a like a button that you click in your med module. So it's super easy, and it actually like pops you into a screen without leaving NextGen, that you can see the actual full ORS report for that person within about 10 seconds of pushing the button.
Yeah, it's nice.
Okay, Tiffany, sorry.
No, that's okay. I was just going to say, I think we had some follow-up items from our last call that maybe we can walk through, and I was going to turn it over to you.
Okay, thanks. I'm just going to pull a little bit of notes up here. So last time we had a great conversation just to kind of get a sense for what was happening at each of the emergency rooms and hospital systems as much as we could, with who was doing bridge prescriptions and who wasn't. We also had you guys share about what was going on in your MAT programs currently and anything that you were already doing with emergency room referrals. We talked about some barriers logistically, both from the FQHC side and from the ER side, and we had come up with some next steps. So the next steps were that we agreed to meet monthly for at least 3 months. And if we can get some momentum going, maybe do some work by emails in between. And then today we want to focus on trying to create some action steps around the other things that we identified as next steps. So I'm just going to remind us what they were. One was to work on creating a more formal and uniform referral process for eventually all ER to FQHC referrals. Another item we identified was creating a list of important ER contacts, including social workers and OUD champions. And on that same contact list, also clearly identifying the FQHC MAT program contents. And then we would like to share that with all the participants so that we can start to help communication at least. The last item that we had identified as a next step last meeting was to have the health centers begin to define what they believe their current capacity is for emergency room referrals, what that method of emergency room referral would look like for your current programs, whether that would be a defined time slot for an emergency room appointment to be taken or walk-ins, and to begin to, I think for yourselves and then kind of help us as OACHC understand how that's best for you. So we're going to come back and tackle each of those for a few minutes in our remaining time and just see if we can get some brainstorming and some ideas. But I wanted to remind us just of some of the things that we had identified as important elements to the final process, trying to match the length of the ER bridge scripts as precisely as possible to the day of the FQHC appointment as a means to have as high a percent showing up for those appointments as possible was identified. And then we identified that the ER needs to know for each of the health centers that are willing to take ER referrals, they need to know when the appointments are, or if they're walk-ins, what the walk-in times are, and kind of the addresses or locations so that they can help patients align to what transportation will allow them to do or what is best for the patient. From an FQHC perspective, we identified one of the current barriers for those who are working with the ERs is you need a way to know who the ERs are sending to you so that you know who to expect in your walk-ins or who's going to be showing up in your ER appointment slots. We did park some other items that I think OACHC will kind of keep track of for now. But I think this is kind of where our work starts. And so if we could maybe just brainstorm what I think might be the easiest place to start, and that is how do we create better communication and most importantly, kind of get this contact list with the right people and points of contact on it. So anybody have ideas for that?
Dr. Dana, this is Audrey from Lutheran Social Services. So you're anticipating some type of directory document with that information on it, creating that for the EDs, or?
We would be creating it for both parties. So I think is at least what I was thinking, but certainly happy to be corrected if I heard the concept wrong on the last call. So I don't know if we need two separate things, one that is a list of ER contacts for you guys as FQHCs and one that is a list of FQHC contacts for the hospitals. But I do know this was an identified item that we need to figure out how to conquer.
And I think, Dr. Dana, even simpler than that was to like which FQHCs are open for MAT patients right now and what are their hours, and make a list of that as well.
Right. Yep. Which was definitely another identified thing. So I don't know if we conquer this by kind of starting with some questions that we ask the FQHCs kind of to send in individually, and we can try to compile something, and at the same time have OSU provide some of their contact information. I think it'll be a work in progress with some of our other ERs, but eventually we'd like to be able to share good contact information with you for all of them.
Yeah, I mean, so is Emily Kaufman. So I envision we're a little more we're stationary, so it's a little easier for us. But so from an ED standpoint, I mean, for OSU we have two campuses. We have the East Campus where a lot of our substance use work has been happening. Then we have our main campus. So at least starting from the East Campus, I mean, obviously I would be a point of contact, but then my daytime ED social workers would definitely be points of contact, and they're going to be working different shifts. Our lead peer supporter would be a contact, and then we also have our inpatient substance use social workers at the main campus. We have one specifically for MAT, and then the East Campus we have Kara Jordan, who is dedicated to sort of all substances. So those are sort of be our main pathways for us, but then we're trying to develop, this repository, this breathing document, it's Google Drive, Buckeye Box, whatever the heck this thing's going to be, where it has all these community networks and, who we know and what times and how we get folks into these different spot. So whoever's there can, know what the pathway is, like Lower Lights has walk-ins on, Thursday mornings or whatnot. So we can keep it straight. Or our case manager, if they're assisting with getting somebody, into certain appointments. Because usually it's our case managers who help a lot with getting into specialty clinics, but the social workers have really been kind of carrying a lot of this work in the department, in the emergency department.
This is Karen O'Brien from Lower Lights. I'm wondering if we could just start with having a list from all the FQHCs as far as their dates for walk-ins and the availability. And then the main contact person of the MAT navigator or social worker who would help to coordinate those walk-ins with the ER. I mean, I'm hearing, I guess I'm kind of visualizing like the ERs would have this list, this breathing list of availability for MAT, so that when they have a patient in the ER getting ready to discharge, they can discuss that with the patient as to what makes sense location-wise for that patient to go.
Yeah, thanks, Karen. I do think that's an important place for us to start. I think some people are doing walk-ins. Some people have certain slots that they're holding in providers' schedules. Not everybody is ready to take patients, so we have kind of different approaches and different places of readiness. So I think we got to get our arms around all of that from each of you and try to put it into a format then that is user-friendly for the emergency room. And then we can certainly get the contact information from OSU and push that out to all of you guys. I think the homework assignment that I'll give myself is trying to get some contact information from some of the other emergency rooms so that we can have a more robust hospital contact list for you all.
And then could each FQHC today or next week send to Tiffany a list of what our availability and contact, who the main contact person would be? Would that be helpful just to start that list?
Yeah, I think so. Tiffany, yep. would you be willing to help compile that and maybe shoot an email out early next week reminding everybody about the request and kind of bullet pointing the informational items that we want?
Yeah, absolutely. And I just put my email in the chat too in case it's gotten lost in your Outlook.
This is Kelly Steele with Primary One Health. I'm also wondering about the referral feature in CliniSync because our last meeting with them, it seemed as though that most of us are in some way engaged with that system. I don't know that I know enough about it, but I at least wanted to put it out there for those of you who may be a little bit more familiar with that part of CliniSync.
Thank you. I think that is another great consideration that we had kind of put in our OACHC parking lot, like what role can we automate somehow through CliniSync for some of this? Do you know from an OSU vantage point, how you guys are utilizing CliniSync?
Yeah, I was gonna actually, I was getting ready to text my social worker, Haley, because I don't know how to access CliniSync. I've heard about CliniSync, but I thought the social workers, Haley, is that something you're able to access?
I have honestly never even heard of it.
Well, I think Megan somehow was able to access it. So, so I don't know if it's because when we log into our EMR, we log in under certain profiles, and I had one of my social workers, one of the other ED social workers, had shown me actually how she could do it, but it's not something uniformly that's done. So I don't know a lot about it, unfortunately.
Okay, well, that is something that we will definitely try to get a little better clarity on from our OACHC connection to CliniSync. to try to ask them if that referral module is something that you guys at OSU already have access to, number one, and number two, try to do a little investigating about how it might be used to communicate back and forth about referrals, because that could solve a lot of problems, Kelly. It could tell us who's being referred or steered our way, right? But it also might give the ER the ability to see when without having to go to a paper list. So we can definitely continue to try to research that.
I also, we recently started working with REACT. We have a Primary One Health behavioral health, it's a behavioral health liaison. Most of you might know him, Will Burton, who formerly was with Maryhaven. So we've been starting to look at how to work through that avenue, at least with OSU and Southeast, because of all of those interworking connections.
Yep. And I do think
so.
Yep. I think that's another important, an important thing that we had on our radar about how does that tie in and become a part of this referral process. So back to our kind of rudimentary starting point of gathering information from all of you. Are there any information points that you think are important besides location, method, like times for your appointments or walk-ins, and the point of contact for your program? Is there anything else we should be asking you to help us gather?
Are you interested in an administrative point of contact and kind of a scheduling / intake point of contact? Because for us, those two things will be different depending on what the agencies who are wanting that information are wanting from us. You know what I mean?
Yeah, so I think it's important to give us whatever you think the ER would need to know. Like, do you schedule an appointment for MAT by calling the MAT nurse, and here's that nurse's name and extension? Or do they walk in and there is no like scheduling or administrative thing to consider? So I guess maybe we'll just put out kind of the broad buckets and you guys kind of try to be as complete as you can be with what you send back.
Okay, thank you.
So I know we only have about 15 minutes left. So if we could spend that time maybe brainstorming what next steps beyond this kind of initial list and communication starting point and trying to identify which health centers are ready for what can we begin to do around a more unified, formal kind of best practice referral process? So that might not be something that any of us can flip a switch and do today, but if we were going to design the best referral process for patient care, how do we start to work on that? Is that something that we should continue to try to tackle with all of us and all, a number of people on a call? Should we think about a smaller work group that then brings a more process mapped and thought out process forward? I'm just kind of talking out loud, so you guys please like weigh in and interrupt what you think we can do to really get this ball rolling.
This is Jennifer from.
Go ahead, sorry.
This is Jennifer from Southeast. Sandy and I were just talking offline, and we really see, yes to what you've just said, we also see a role for peer supporters in being linked with patients as they're waiting for that bridge script appointment, or as they're waiting for their first appointment, even if they don't fill the script, just to have a point of contact and support.
Okay, great. that could be an element of the process that we put forward, right?
Agreed.
Yeah, I think that's a great idea about the peer support.
Dr. Dana, I'm curious if you've had conversations with anyone in any other states or in any of the other systems that are maybe similar in size to ours, to see what other places are doing.
I don't know about similar. I can just give you a couple of vantage points. Part of California being one of them, they created a fairly large multi-county, multi-community kind of one unified process where all the hospitals got on board and all the community health centers and treatment facilities got on board. And basically they all follow like one path it's kind of, I don't know HIE, but it's kind of like what we're talking about with a notify or referral use through CliniSync. So basically they created a system electronically that allows them to do this in a seamless manner.
Okay.
I don't know without the help of CliniSync if we'll be able to get there, but that's probably the biggest effort I'm aware of, where everything's kind of going through the same information data management clearinghouse type of approach. Then on a much smaller scale, in other communities, there have definitely been initiatives where the ERs and the treatment providers, as well as the FQHCs, basically did what we're doing, where they figured out who's doing what and how to communicate it and how to streamline it as much as possible. The third thing that I'm aware of nationally is that some either hospitals or communities have developed bridge programs because they couldn't figure out how to keep all of the communication and things all together. And so they just created kind of a one place for patients coming out of either residential and needing long-term MAT care or out of the ER. Like you go here and they take care of you for a little bit and they figure out with you how to get you to the long-term place.
Yeah, that just to add on what Dr. Dana said, Metro has a little, I talked with Joan Papp, who runs their sort of project up there. They have a bridge clinic that they use, and OSU, we actually have funding secured. We started a bridge clinic at the main campus, but it has a little bit more of a mental health focus. But the goal is within the next year, we'll actually have a bridge clinic housed over at OSU East near Talbot Hall. So our hope is to have something like that.
So I don't know if anyone else is aware of anything else as a model or anything else to consider. Certainly happy to hear anything you know happening elsewhere that's working well. Okay, so back to how do we want to tackle this? Do you want to keep trying to tackle it on this call and do some planning and work on a process altogether? Do you want a smaller group to try to do something between this call and next call as a starting point?
This is Katie Reinhardt. We've kind of already started, Dr. Kaufman and Dr. Teeter at Talbot, we've kind of already started a process. So I think I would appreciate if we would just continue with developing how, especially since we're right at East, and even we could even be a part of the bridge program, that we kind of get that figured out on our own.
Okay. What about for the other health centers? Do you guys want to keep doing it individually, or do you want to try to come up with a more unified referral process?
This is Cynthia from the Health Center at Faith Mission. Since I'm new to all of this, I would like to do it in a group so that I can kind of get a feel for what's really happening, if that's okay.
Absolutely.
Dr. Dana, this is Kelly again. I agree that some sort of group centralized referral process would be helpful because, you know, even if a patient has been seen at Primary One Health in the past, but it was 2 years ago, but they live in Whitehall, like, you know, right down from Heart of Ohio, or, you know what I mean? If there's another program or treatment provider that's a better fit for the patient, I'd rather the EDs be able to sift that out with the patient so the patient can decide, you know, what kind of treatment and level of care and all of that stuff. That way they can be engaged in that conversation. I feel like it'd be really hard for the EDs to be able to have that conversation if there's not some sort of central process or program to help them with that, you know. It's just my thought.
This is Karen. I agree with that. I'd be more than willing to participate in a group for looking at a central referral.
Okay, great. Anyone else who hasn't spoken up have an opinion one way or the other? Okay, so in the interest of time, we will, OACHC, Ashley, Tiffany, and myself, we will kind of get together offline here. And we'll make sure that we get out the initial query so that we can try to put together the reference document. But we will also chat with ourselves about kind of how to really get the lift of creating the more formal unified process and those conversations with those of you that want to remain engaged in them going. And we will let you know what the next steps are going to look like from here.
Awesome. Thank you, Dana.
Oh, sorry, go ahead.
Nope, I was just going to add, I will send a follow-up email, and happy to send the recording and some notes again. But if you have the information ready and you want to just send me who your person of contact for your MAT program would be, your location, and how to get a patient scheduled via email, I can definitely start compiling.
And Tiffany, were there any other grant related reminders or things that you wanted to do before?
I think we'll be meeting with the FQHCs next week. You should all have the monthly call on your calendar for June 11th. I believe it's at 3 o'clock, and we can do some debriefing or some further discussion if anybody has something that comes to mind between now and then. And then I can bring it back to this group the next time we meet. It sounds like I'll need to send out another doodle poll as well for this group to see when we can meet in July. So look for that coming from me as well.
Okay, anybody have any last questions or comments, concerns? Okay, well, I hope you enjoy the weather this weekend and are able to have a good weekend.
Thank you.
Thanks, everybody.
Thank you.
Thank you.
Thank you. Have a good weekend.